Hi, everyone. Grab a seat, get comfortable. You have just entered the Smartest Doctor in the Room podcast. Today's topic is thinking like an immunologist. I truly believe that if we are ever going to solve some of the mysteries behind diseases such as long COVID, myalgic encephalitis, also known as chronic fatigue syndrome, and even chronic Lyme disease, that understanding immunology is going to be the key. I may have mentioned this before, but sometimes when I'm at a party and I meet someone for the first time and they find out I'm a doctor, of course, the next question they ask me is, "What kind of doctor are you?" And when I say I'm an immunologist, I get this quizzical look as if, "What kind of patients do you see?" Of course, because I'm not a plastic surgeon, they go on to the next person. But I explain to them, if they are willing to listen, that I treat patients with complex diseases such as chronic fatigue syndrome, candida overgrowth, mast cell activation syndrome, the type of conditions that require a lot of intensive medical detective work. I've done a video, I've mentioned this, I call myself the 10th doctor because so many of my patients have seen at least 9 other doctors before coming to me. But I have a special guest today, Dr. Terry Harville. He is a super immunologist, meaning the immunologist, and I mean that with a capital I. His credentials are beyond impeccable, and I've had the pleasure of enjoying his column, Immunology 101, that's in a magazine that I get called IG Living for immunoglobulin living. It's mainly for physicians who treat patients with immune conditions. Dr. Harville is a professor of pathology and laboratory services and internal medicine at Arkansas University Medical Center. He's also the medical director of the HLA and histocompatibility lab and the immunogenics and transplantation lab. And he's got a couple more things, but we got to get into the podcast. So I'll let you look that up on your own. So anyway, I'm really hoping that Dr. Harville can help us in his elegant way of simplifying and clarifying some of the immune mechanisms that are in these conditions. So it's really my pleasure to welcome Dr. Terry Harville to the podcast.
Thank you very much for the very kind introduction.
You're welcome. Okay, what I always like to do to start out with is a little bit of background stuff. And I'm just curious because you and I have been around the corner a few times. What got you interested in the field of immunology back when you decided to do training? Because they're obviously, and you obviously have in a lot of areas too, transplantation, pathology. So I'm just curious a little bit on that background.
Yes, actually, I started out as an organic chemist and then went into biochemistry, molecular biology for my PhD. Similar to today's political climate where money is being lost for research purposes. In 1980, money was lost, and I realized I needed to have a job where I could earn a living. So I decided to go into medicine and go to medical school.
Mm-hmm.
At that point, one of the other things that I recognized as we were starting to deal with things, we treat disease by giving poisons to people. We poison them to kill the bacteria. We poison them to kill the cancer. We always are giving a poison. It seemed to me that we should be able to utilize the immune system more appropriately, be able to adjust the way the immune system is functioning. For example, use immunizations to help eradicate the microorganisms that are creating a problem, adjust the way the immune system is working to help deal with autoimmune disorders, and adjust the way the immune system is working to help deal with immune deficiencies and such, and use the immune system to help deal with cancers. During my lifespan of doing this, now over 40 or more years, we are beginning to do that. And so in the 90s, we started using medications that would help deal with the cytokines that are involved with autoimmune disorders. So an anti-TNF medication to help us to try to deal with autoimmune disorders. Likewise, we started more recently using what are known as PD-1 inhibitors to help boost the immune function against the cancer. And subsequently, we are altering the way T lymphocytes work by adding to them specific receptor molecules to target them towards specific cancers. And so the so-called CAR T therapy, where we can use the immune system to fight the cancer, again, rather than trying to give people poisons. So the bottom line was, it seemed to me we should use the immune system.
Yeah, I am smiling. I guess people on YouTube will be able to see this, not my podcast people. You just knocked out three of my questions because you explained it so, as I said earlier, eloquently. Because what I was going to talk about, and just I'll mention it briefly now, is that I feel like most of my physician colleagues, in various specialties who are terrific doctors, they don't really think immunologically. They're looking at, like, as you mentioned, targets. Oh, we got to hit this with antibiotics, or this is with antivirals, or now obviously with the rheumatologist with biologics. Not really getting, thinking immunologically. How can we get our own immune system to be enhanced? And my next question was, I teach at the medical college, like where you also teach at yours, and I tell my students, I said to them, you have to learn the language of immunology. And I think immunology and genetics are probably the most important areas of the future. And I think AI will help with that to really get some major breakthroughs. But you led me to probably the most important question I want to start to look at today is that, because again, this is what I do with my patients. I explain to them, especially with my chronic COVID patients, that in my immunology training in the late 1980s, early 1990s, it was at the height of the AIDS epidemic, and I was working in New York City. We were a big AIDS center, and obviously, all our focus at that time was on T cells and B cells, and I think the public's pretty much familiar with that, from AIDS. But I think what's not been really appreciated again all those years, and I was fortunate to do a little research in some other areas on this, was the importance of cytokines. Because I know that it's not like the sexy thing that makes all the headlines, and doctors don't even talk about it as much, even though it's behind so many treatments today. But I try to tell my patients that these are immune hormones. They are being sent between the cells, and they, in their own way, are as important as endocrine hormones like thyroid and testosterone and estrogen. And again, patients are seeing a lot of ads on TVs against for these new biologics that are targeting this. But I want to ask you, because we're going to really go into this with long COVID and a lot of things that you have written about. How would you, maybe better than I, describe how important and what cytokines are, and why should we be very aware of them?
That is a very, as you've been stating, is very critical and very important. And what people don't think about is inside our body, we can think of things as sort of happening like a soup. And so you have the cells that are floating in there, you have the serum plasma that's carrying the various proteins that are present. And there are going to be these protein signalers, the hormones, as you stated, that are coming from the different cell types that are there to influence other cells into doing some type of activity. And what I have people try to imagine is think about when they learned vector addition back in high school physics, where if you add the distance that's as as an influencer on something and what another distance is influencing, then the final position is based on the additive amount of these things. So
Mhm.
now, if you start looking at all the cytokines that can be affecting a cell, you're going to have those that are pushing towards activation, as well as those that are pushing towards anti-inflammation or slowing down or inactivating. And so a cell position, whether it's going to be activated to carry out some kind of process, is going to be the additive effect of all these different components that are occurring. And
Mhm.
so if you have an infection occurring, then the infection is affecting the cells nearby. So the
Right.
epithelial cells, the endothelial cells, and these will be releasing interferons and chemokines that go out to say, I'm in trouble, I need help. And
Right.
so these then will start bringing in first monocytes, macrophages, and neutrophils that are trying to help gobble up, eat up any debris, eat up any of the microorganisms that are present, so then it can then subsequently present those to the adaptive immune components. But it's also trying to pull in T lymphocytes as well as B lymphocytes and NK cells that can look at what's going on and assess the situation. So if you have the macrophage that's been attracted in, that can be chewing up some of the material and start now presenting it on its cell surface in what are called the HLA molecules, You have a T cell that has its own specific receptor that can recognize that component. And if it can recognize the antigen that's present there, it will then start internally receiving its own signals, as well as sending out its own set of cytokines to help attract more T cells to the area. And this then initiates a specific immune response that will then attract in, for example, what are known as the CD8 or killer type T lymphocytes to try to kill off the infected cells and kill off the microorganisms that are creating the problems there. And so the process we have to think about is this soup of material is occurring. All these chemical signals are being produced by the various cell types and the active effects that they're occurring. Now, as long as the infection is occurring, this pushes towards the inflammatory process to kill it all. And once the infection is clearing, and then the counteracting signals are coming in to try to slow things down and then to reduce the inflammatory process. And so you mentioned things like long COVID and chronic fatigue and Lyme. What happens in many of these conditions is that the signals get turned on, but don't get turned off.
Yeah, I want to get to that. So I am going to have to stop you because you can't. I have all my good stuff here. I want to just mention to the listeners too, because this is what I'm saying. Thinking like an immunologist. I actually, if you can hear, I've had a cold. I won't say it's a cold. Last week, I had started to feel a little bit sick, and but being doctors, whatever. Too, I put my mask on. I went to work that first day. I said, oh, it's a little cold. Just suck it up. We're used to working, overnight on call over the years. But the next day or two, I felt awful. And so I got the really good Pfizer COVID and flu test. And a little bit to my surprise, it was negative. So I said, okay, I don't have COVID, I don't have flu, but I got something because I was just feeling awful. I didn't have a high fever, but my body ached. And I'm going to explain where I'm going with this. So then I waited another day or two. Again, being a doctor, and I do recommend this for patients a lot, actually. I got a hold of what they call a nasal swab that does 20 different viruses, like a respiratory panel. And I said, I don't know. There's got to be something here. So I swabbed myself. I sent it off to the lab. It came back very fast because I guess it's like those preliminary chain testing. And it was parainfluenza type 3. And the reason I'm explaining this all to the listeners because I felt awful this past week. Today, in the last day or two, was the first day I feel like 90% better, although I sound sick. But all I kept on imagining in my mind was that's the cytokines, that gamma interferon. It's hauling in all of these cells to fight the infection, but it's making me feel terrible. But it's part of the game. And the reason I just gave my own personal story and what I was so excited to have you on, because I think you get this, is that I try to explain to a lot of my patients that I see with long COVID, the patients I've seen for decades with ME, CFS, and even the Lyme disease patients, but I don't see as many because they go to, quote, Lyme specialists and get months and months and years, sometimes with antibiotics. And I think they're all missing the boat. I think in these cases, it's no longer a chronic infection, but it's chronic inflammation. And I wanted to ask you, I think you're going to be in agreement, but I want to hear if you are. And how do we get physicians and the patients to understand this? Because they keep on thinking we got to throw, an antibiotic at it. We have to throw an antiviral at it. I disagree. I think we have to, and I've had a couple of other podcasts with excellent researchers in long COVID showing that it's this cascade of interferon gamma setting off decreased absorption of serotonin, of tryptophan that doesn't make enough serotonin, this whole cascade. But I'm sorry for going on and on, Dr. Harville, but do you agree? Do you think that's what we're missing? That it's just chronic inflammation we have to target, not an actual ongoing infection in these diseases?
Correct.
You
And
do?
so
Okay.
that's the bottom line.
Yeah,
And I can give you a little bit of a simple explanation, hopefully.
sure.
And the a part of the innate immune system that's involved in activating all these things are the macrophages. And they basically exist in two separate types of states. One is known as M1 and one is known as M2. The
Okay.
M1 is the activated inflammatory state, M2 is the anti-inflammatory state.
Okay.
And what seems to be occurring in these conditions, at least based on our studies and what other people are producing, is that once these types of infections trigger the immune system, you trigger the macrophages into an M1 state and they persist there. And so they continue to go there, and you continue to see the signals, the chemokines, cytokines, they're indicative of an M1 state. And so,
Mm,
for example, our treatment for long COVID is to try to convert the microglial cells, which are macrophages in the brain, from an
mm-hmm.
M1 to an M2 state. And
Wow.
one of the ways of doing this is low-dose naltrexone actually binds to receptors on the microglia that then cause the microglia from converting from an M1 to an M2 state. And when we use low-dose naltrexone, and we use celecoxib as an anti-inflammatory, and these
I'm sorry,
seem
what is that last one you just said? I never heard that.
celecoxib, brand name Celebrex.
Oh,
Uh,
Celebrex. Okay.
yeah, it passes through the blood-brain barrier better than other non-steroidals do.
Interesting. Okay.
And so the combination of these seem to help convert the microglia from M1 inflamed state to an M2 anti-inflamed state, and the brain fog lists.
Wow. That's fascinating. I hope my listeners are listening to this because it's interesting, and we're going to get into this a little bit more too. I want to get into a little bit more like pathophysiology, but that, yeah, yes, again, it's using medications, using medications to turn down, lower the amplitude of the inflammation state. And anything that does that is going to make the patients feel better. And then I always tell patients, I hope I'm saying this correctly, that hopefully the immune system is very interesting. Once it starts to sort of get back in balance and quiets down, it's like anything else. It will hopefully stay in that state. You
And
agree?
that's sort of the goal is
Yeah.
that usually it takes, after an insult, it can take 2 to 7 years for the immune system to recover back
Oh,
to
wow.
its original state. And so, and in some patients I've dealt with, it's been more than 20 years. Um,
Oh, jeez.
and
Okay.
and for example, Epstein-Barr virus does a big number on the immune system, and because it remains present within the body, it tends to, and some patients maintains that inflamed state, and can continue that going on and on and on.
We're going
You
to
were
get it.
just
Well,
mentioning
yeah.
you were mentioning some of the medications. The other medications that we think are important to help calm down the macrophage microglia type cells is also vitamin D, and we recommend 2,000 units twice a day. And
Mm-hmm.
that tends to also help calm these down, converting them back from the M1 to the M2 state.
That's a great suggestion. Let me ask you again. I was gonna get into it later, but you're bringing up so many key points. I use gamma globulin, but not like full replacement. I'll give you. I try to really explain this to patients because, obviously in our background, I used earlier in my training, full replacement gamma globulin therapy for immune deficient children, and generally with primary immune deficiencies, certain ones. And it's a lifesaver. It's a game changer. What I do in my practice is I give actually a small amount of intramuscular gamma globulin. And what I'm trying to achieve, and I was doing this for years with chronic fatigue when again, we thought related to Epstein-Barr, was exactly what I think what you were saying is trying to damp down the immune system without suppressing their immune system. Now, I know it's not a specific therapy, but we're trying to get a broad-based thing to get these patients better. Does that make sense? I mean, because the gamma globulin does reduce cytokines, correct? I mean, it brings certain ones down.
When you look at replacement immunoglobulin, there are anti-cytokine antibodies. There are also other small molecule components that act as an inflammatory component itself. And so, but there are also parts of complement and other proteins that can add to inflammation. So you've got this mixed component of
Hmm.
things. And when depending on what's going on, the sort of determines how much needs to be present. And
Yeah.
so if you look at a disease like pemphigus, for example, you only need a small amount of immunoglobulin. So 100 milligrams per kilogram can help with pemphigus.
Mm-hmm.
When you deal with other conditions that have a lot more autoimmunity present, you really do need the 2 grams per kilo.
Okay.
Um, but that was based on work that was done initially with Kawasaki's with Stan Schulman, and they started out with half a gram, didn't work, a gram didn't work, gram and a half didn't work, 2 grams it worked, and
Mm.
so that became sort of the standard for then dealing with other diseases. And then what we've tried to do subsequently is see back down to what may work for different ones.
Mm-hmm, mm-hmm.
And so, for example, some of the neurologic brain diseases,
You're
ADEM,
right.
might be able to use a lower amount. A gram per kilo may be been sufficient to help deal with that. And again, we talk about giving these on a 3 week to 4 week basis type of
Right.
a thing.
But the rate limiting step with this is unfortunately the scarcity and the cost. Is that
Yes,
sometimes that's the issue? I mean, because otherwise,
yes,
I mean, I found over the years it would be much more widely used, for patients. It's just that, people hear, IV gamma, 3,000 or something, whatever is an infusion, and the insurances won't cover it, unless you have one of these three diseases. The
exactly.
doctors are stuck, so then they back away. They don't even bring it up as an option.
That's exactly correct. And many, many years ago, one of my good friends, Richard Schiff, who was a really brilliant immunologist, unfortunately passed away a number of years ago. But Richard and I had a discussion about this. And in a fantasy world, we thought that what should happen is everybody should donate immunoglobulin, this process, and then we all receive back monthly infusions.
Mm-hmm.
And the thought experiment was, how could we help deal with all forms of diseases? And in the thought experiment, that kind of approach where you use your mixture of immunoglobulins with everybody else's, that you'd be getting back from the total all the items that you need to help control the different disease types of processes that were occurring in you. Obviously, that's a fantasy.
Yeah, yeah. It sounds like a fantasy, like a spiritual thing. Like, the community overall helps everybody.
Yeah, yeah.
Right.
But the concept was based on the experiments that he had done in mice
Wow.
that we dealt with that showed that you get benefit. So persons with normal immunity actually show benefit by giving them IVIG.
Really?
Yes. So
Wow.
because of
Wow.
again this modulating effect that you can have.
Fascinating. Let me ask you this too. I mean, because your knowledge is pretty extensive. I did some work for a while, following Dr. Bruce Patterson's work. I've had him on the podcast. I don't know if you're familiar with him. He was originally
Mhm.
out of Stanford and he opened up his own private kind of institute.
Right.
And he also, it sounds a little bit similar to you. I mean, he believed the spike protein infecting what's called monocytes was the key driver, and that he had come up with an algorithm that helped kind of classify long COVID patients. Now, I did this with many patients, saw a lot of variability, but it is impressive when you get these cytokines that that you're looking at and saying, really, these things are high. I mean, this might be explaining a lot of stuff. And I saw in one of your presentations that you even said that IL-1, for example, or IL-1RA is elevated in long COVID. Can you just comment a little bit? Do you think, because most doctors are not measuring cytokine panels in long COVID patients, but should they be? I mean, could we maybe get more information out how to target and treat a patient? Like if a specific cytokine is very high, maybe they would benefit from, and I don't mean to be controversial, but like ivermectin. I've never used it, but Bruce had some like webinars where they were showing like some of these meds, they actually inhibit the cytokines. That's how they think they're working. So I was just curious on your thoughts on that.
Sure. And as you know, Bruce Patterson also has an algorithm for Lyme disease based
Right. I'm aware. Right. Right.
on
I'm curious
similar
about your
types of things.
thoughts. Yeah, I'm curious about your thoughts on that. But if you're willing
Yeah,
to weigh in.
I've looked at the data. I've looked at the cytokines they've shown, and we're doing similar experiments and also the literature. And I think that w- when you look at things, you try to go through and generate a positive predictive value, negative predictive value, and in a statistical manner. And um, while you can prove something statistically, it may or may not provide you the benefit that you need.
Correct. Right.
And so um, the, there's truth in what's going on, but I think that there are some of the items that are being missed. We are trying to organize our publication on this, and so I can't give you too many details.
Okay.
Uh, but when we look through the literature and we look at what we've been able to do, there's a slightly different pattern of ones that we think that's more relevant.
Okay.
And as you mentioned, that the IL-1 is an initiator of the immune responsiveness. It's primarily produced by macrophages, but also by other tissues to try to attract cells to the area. And in patients with autoimmune disorders such as rheumatoid arthritis, continued production of IL-1 is driving the inflammation. IL-1 in the joints leads to joint bone destruction. And so the IL-1 receptor antagonist, anakinra, has been shown to decrease this inflammatory process and prevent the bony damage that occurs in patients with conditions like RA. And what we found is that patients with long COVID have continued high levels of IL-1 as well as IL-1 receptor antagonists. And so, which looks like somebody that has rheumatoid arthritis. And so we suspect that the possibility is that treatment with anakinra could provide some of those patients with benefit. But as you're stating, with the overall chemokine cytokine pattern that's present, what we're looking at is we think, and there's been some publications of people also proposing this, the JAK inhibitors may be ultimately what's needed because of their more or less broader effect and better effect over calming down multiple different cytokine chemokines rather than only a singular one.
Mm-hmm. Interesting. And you don't have to worry about too much about immune suppression in any of these cases, or the benefit of suppressing the immune system is worth it versus, being, with any of those kind of medications you sometimes, was it tuberculosis? There's certain unusual infections they could be prone to.
Oh, absolutely. And those
Yeah.
are a concern. And over age 50, the issues with clotting and cardiac disease. So all these things are of concern. But what we're very concerned about is and there's predictions of a wave of dementia by 2050.
Oh, God.
And we're very concerned about this as a consequence of the brain effects in long COVID.
Oh, God.
So I think that many would agree that prevention of dementia may be
Oh,
worth the potential
yeah,
adverse effects.
I agree. Well, let's go one more thing on COVID, and maybe want to move on to something else. But I've been following very closely your articles in IG Living on long COVID, and you talk a lot about your interest in the ACE2 receptor. And for our listeners, just to, again, and we'll maybe show a pictorial of that. Essentially, I think our listeners can visualize, that COVID virus is coming in with that spike protein, and it has to dock on the cell. And the way it lands on the cell is it attaches to this thing called the ACE2, which stands for the angiotensin converting enzyme 2 receptor, which is a very prevalent receptor. I remember I was doing some research on this for a possible book a couple of years ago. I mean, it's obviously heavy in certain locations. I forget which ones, but certain areas of the body, probably the respiratory tissue. But then you go on to say, I think it's important that, and we try to explain this best to the listeners as we can, is that the body, either naturally makes antibodies, or if you give a vaccine, makes antibodies to the ACE2 receptors, or makes sort of autoantibodies. I mean, I know I'm messing this up. So can you maybe, the best you can, explain this?
Sure. And also, just to add before going further, this is a reason why we lose antibodies to COVID so quick, and we need to have the booster immunizations every few months. And so when we look at ACE2, and as you're mentioning, ACE2 is found very prominently at the heart and the kidneys. It's also found in the lungs, the GI tract, the brain. It's found throughout the body. The two most important organs are the kidneys and the heart because of its help in regulation of blood pressure. And so,
Right, correct, right.
one of the problems is if you generate antibodies against ACE2, you're promoting dysautonomia. So you're going to promote POTS and the other issues associated with the inability to control your blood
And
pressure.
I'm sorry to interrupt you, that along with brain fog, the patients
Yes.
I've seen, is the two most devastating things, where people can't leave their house, they can't function. I mean, it's just life-changing.
Our clinic, because it's a neurodevelopmental clinic, the patients come in, all have brain fog. almost all have POTS,
Mm,
and fatigue, and non-exertional fatigue are the main presenting symptoms. Back to
mm.
ACE2 to try to explain what's
Yep.
going on. As you were noting, that the virus has a component on the spike. It needs to have a way to be able to invade into a cell.
Right.
So the coronavirus um, has a part that binds to the ACE2 protein that's found on all these different cell types. And then from there, that helps facilitate the entry of the virus into the cell. And so the vaccine manufacturers focused on the spike protein, in particular, what's called RBD or receptor binding domain that binds to ACE2, because they're trying to produce what they consider to be a neutralizing antibody. And neutralizing meaning that if you make an antibody against that part, then that part can no longer be accessible to bind to the ACE2. And that
Right.
would prevent the virus from being able to bind.
Right. It's like a film getting in between. It's like a block. It gets in there,
Yeah.
blocks. Right. Okay.
And as it goes a blockade because it's bound up
Right.
and it can't
Right.
find the target.
Competition. Yeah.
And so whenever we make an antibody, Niels Jerne back in the 60s um, uh, tried to understand how our antibody repertoire is generated. How do we make all of our antibodies? And how do we generate a regulation of antibodies so we can maintain them at the right level? And what he proposed was that anytime you make an antibody, that part of the antibody that binds to things is new to the body. It's a new
Right.
protein. And so it's something the body has not seen before. And so it acts as a new antigen for further antibody production.
Right.
And so now you make an antibody that's the anti-component of that.
Right.
And the original antibody is given a name that's called an idiotype, meaning that
Mm-hmm.
that's the specific component that has a specific unique structure. And
Right.
then when you make an antibody against it, it's called an anti-idiotypic antibody or
Right.
anti-idiotype. And so you can think of this as sort of like a mold and a cast. And so you have that cast that makes the mold, and then you have that mold that's out there, and now you generate a new cast against it. And that new cast would be the anti-idiotypic antibody. And now that new cast will act to make a new mold that's going to be an anti-idiotypic antibody. And
Mm.
this can go on ad infinitum.
But is there a benefit to this? The immune system is very smart. What is the germs, whatever, figure out like why our body does this? Is
It's
there
for regulating our antibody production and for maintaining antibodies at a certain level. So
okay.
if you have an infection, you've generated your antibody, you
Right.
have an infection, and you deplete an antibody. The body needs to know that it's depleted that antibody.
Okay.
And so it knows that because there's a hole that has occurred in that idiotypic anti-idiotypic interactions.
Okay.
And then those B cells are the ones that get activated up to replenish the antibody that was missing.
All right. So there's a logic to this.
Yeah, yeah.
It's
And it allows us to maintain our antibody levels at 1,000 milligrams per deciliter for IgG, for example. And
okay.
but what happens here is the anti-RBD antibody will act as a new source for producing antibody, and the antibody made against it will look like ACE2.
Okay.
And now you generate antibody that can bind to ACE2.
So that's good because now you're blocking the virus from having the
Right,
ability to
and
get
you
in.
block the virus, but now you're making antibody that binds to ACE2 and blocks it. And when you block it,
That's a
you
problem.
increase the body inflammation because
That's a
its role is to cleave N7 to get rid of the inflammatory component angiotensin causes.
I'm so sorry. Can you say that one more time? Because there's a question I want to ask you about medication. Can you say that, repeat that one more time, what you just said about
Right. So if you make an antibody to ACE2,
two? Right.
it blocks ACE2 function.
Right.
ACE2 function is to cleave N7 angiotensin, which angio-1 cleaves it into small products. These small products are very inflammatory and cause lots of inflammation. And
Mm-hmm.
so they also help increase the blood pressure. And so ANG2 is there to cleave it to help uh, uh, to get rid of the inflammatory component that's
Right.
causing the vascular endothelium to become inflamed.
Right. Okay. The reason I'm asking this is because, again, the obvious thing is like we do have ACE2 receptor medications, which are used for hypertension.
That's correct.
Can these potentially work the same or better, or do they, is there,
The ACE, ARBs, angiotensin receptor binding, work on ACE1 and not ACE2. Okay.
okay. I
So
didn't
they
realize that.
do provide some regulatory benefit because of the um, benefit regarding the angiotensin that would be a problematic,
Okay.
but they don't. Studies have shown they haven't provided benefit against the virus, and
So, I mean, if they were able to invent like a medication that was an ACE2 receptor blocker medication, would that be dangerous? I mean, or
if
it
it
could,
if it binds to ACE2, it really end up with people with POTS.
that's not good.
No. So what
Okay.
you would like to have is a decoy
Mm,
that would be non-immunologic decoy that could neutralize. Okay. Now,
yeah.
alternatively, if they've asked me to design a vaccine, I would have gone for a nucleocapsid protein component that
Right.
would not only that structurally has to can't be altered, so
Yeah.
it structurally needs to remain the same, and would also work with other coronaviruses.
Why do you think they didn't do that? Why do you think, because nuclear, just like I tell patients too, like the way you know somebody has natural immunity versus vaccine is by
Yeah,
looking at the nucleocapsid
exactly.
antibodies. If that's present, that means you have natural immunity
That's
versus if
correct.
you have the IgG. But I'm saying, why do you have any knowledge of why they didn't choose that as the
I,
component?
I think people were narrowly focused,
Uh-huh.
thinking, I want to neutralize the virus, and not
Right.
thinking about the total issue. I don't
Mm-hmm.
think they had people thinking in a 3 to 60 component about what you want to do with dealing with things. And,
Interesting.
and since if you go back and just think about how do we deal with tetanus, we make an antitoxoid antibody. So you
Right.
deal directly with the component of things. And
Right.
so they're thinking of blocking the binding and not thinking about the ultimate consequences of it. And
See, that's
so
what I'm
we
talking about thinking that's why I kept that's the title of this talk, thinking immunologically. That's
yeah,
what
and so we maintain nucleocapsid protein antibodies that work quite well, but we can't maintain anti-spike, anti-RBD proteins because the immune system in most people detects this autoimmunity that's occurring and shuts down the production.
so which is more valuable to have then? I mean, just not to get political, but if we were seeing a patient that had good nucleocapsid antibody titers, would they really need boosters? I mean, aren't they just better off having the antibodies that they have?
Um, that's a great question, and um, the it's possible that that would be sufficient,
Okay.
but we don't have the data to know that.
Okay.
And so um, what we do know is that the more you vaccinate, the more you influence your immune system to shut down the autoantibody production.
So is that good?
That's good because you
Okay.
don't have
Okay. I
autoantibodies.
just, I've had Paul Offit on the podcast. You probably know him. He's one of the top vaccine experts in the country. He's on the FDA committee, and we really went in depth about this. And he's obviously pro-vax, but
Yeah.
we've had a discussion about not doing boosters. It just seems that between natural infection and having the two original ones, most people are well covered. And I hate to say it, but again, because I'm also pro-vax, but these vaccines seem to be incredibly potent. And I had a colleague, a medical doctor, who got Guillain-Barré syndrome from his fourth shot. I mean, nasty stuff. Okay, I'd like to move on to because before we run out of time, this is something that's really been an enigma to me, and I would love to hear your thoughts on this. Is about myalgic encephalitis and chronic fatigue syndrome, which again, I tell patients, I said, it's a basket diagnosis. We don't know what the underlying cause is, although it's hauntingly similar to long COVID. And we know COVID wasn't around 30 years ago. But so, like as you mentioned, Epstein-Barr got implicated. For a while, he got exonerated. I'm talking legal terms here. We don't know. But I guess what interested me again was two things. Was one that a lot of the researchers have written that when you get, or when you get, let's say, for example, long COVID or COVID infection, Epstein-Barr gets reactivated.
Correct.
And I'd like if you could explain to me, because I see the Epstein-Barr antibodies all the time. I see IgM, IgG, which we know so many of us had if we've ever been exposed to mono and Epstein-Barr earlier in our lives. Is there a specific test again? Was it like the nuclear antigen D or something? Like, how do we know Epstein-Barr is being reactivated?
Sure. Let me start by
Sure.
on the MECSF. Um, I when I started in this in medicine, I called all of these conditions post-infectious immunoreactive disease,
That's a good
post-strep
name.
arthritis, post-strep urticaria, what
Hmm.
we now know
Yeah.
as PANDAS,
Oh yeah. Yeah.
post-infectious immunoreactive disease. What was EBV reactivation causing problems, post-infectious immunoreactive disease? Because it's not the virus or the infection organism itself. It's like you were mentioning with Lyme disease. It's not the Lyme being still there. It's the immune system's response to these things and
Right.
not being able to calm back down afterwards. And
Right.
so all of these, I think, have that same underlying basis. The immune system gets
Right.
activated and doesn't get turned off. Now,
Right.
back to EBV is for people, these herpetic viruses, once we become infected with them, the DNA from the
I can't
virus
talk
gets
now.
inserted to our genome and remains present. And so it's always there, cannot come back. So people that have had chickenpox can develop shingles. People that have had EBV can develop reactivation
I'm
EBV.
sorry, Dr. Harville. Can we take a break for 1 second? I
Sure.
apologize. I think a little emergency. Okay, sorry. We're back. I'm sorry. You were saying?
Yeah. So with Epstein-Barr virus, it's integrated in the genome, and so under certain types of circumstances, the virus thinks it needs to escape so it can go out and reproduce itself and infect somebody else, type of a thing. And so what we do to measure these, people that have had a completed Epstein-Barr virus infection will develop IgG against the nuclear components. And so you have then the IgG nuclear antigen component that suggests a completed cycle. If you have IgM components, that means it's reactivated or primary infection. So if there's IgG present and IgM, it's reactivation occurring.
Right.
And
Okay.
then the early antigen is indicating of active disease process, either at the initial or on reactivation. So what I do
Mm,
is I look for the IgM components,
yeah.
the nuclear capsid, and then I look for the early antigen. And the other thing that I do is I ask for uh, plasma to be analyzed by Loomis chain reaction for EBV viral particles and cells. So I have them separate the plasma from the cells. And if viral particles are in the plasma, it means that there's active EBV replication occurring.
Interesting. Okay, that really clarified a lot for me. Boy, I kind of was following that over the years, but I've never heard anybody explain it so clearly. Do you feel, because I know they've tried this, does anything like the antivirals like Valtrex or anything help for this or not really?
Yes, I use Valtrex 1,000 milligrams twice a day.
You do when you feel the ZB
It helps
reactivation.
tremendously because it's a higher dose. I monitor their CBCs at least monthly to
What
make
do you
sure
worry about? A low, like, can it suppress the white count or something? So
right,
the, so, yeah.
it can be bone marrow suppressive, and if it is showing suppression, try to drop it down to 500 twice a day.
And how long
Uh,
would you do that for? Like a month or something? I mean, what's your
I
just
I
typical?
do it until there's no evidence clinically or laboratory wise of the virus. So I generally wait for 3 months of treatment, and then I check again because by that point the IgM titers will have disappeared. And if I'm successfully suppressing the virus, the IgM titers will have disappeared. And if they're still present, I haven't fully suppressed the virus.
Do you think
If,
the long COVID patients are being undertreated in this way too, in a sense? Because
yes,
you do.
yes.
Interesting.
And we have a couple of patients that we are treating now and in this fashion.
Wow. I hope for my listeners, you're appreciating the amount of expertise Dr. Harville's bringing because this is critical. One other last thing on this too, before I move on to one other thing. Back in 2017, I got all excited, out of the Stanford group for EBV, I mean, for MECFS, they said they came up with a cytokine signature, kind of a little bit like Dr. Patterson, but it seemed to have fizzled out. Has anything really ever come up out about, because obviously the mystery behind this condition? Um, is there a way to look at certain cytokines and say, this person most likely has ME?
I think there is, and again, we have been examining um, post-infectious immunoreactive disease. So patients that have been diagnosed with such as pandas,
Mm-hmm.
and which, uh, in my mind, is simply basically equivalent to ME/CSF. And we think there is a cytokine chemokine signature, and some of the articles I'd sent to you. And so again, the IL-1 and the chemokines seem to be the major things. So RANTZ attacks and um,
Mm-hmm.
IL-1.
Because this group, which was interesting at the time, the way they really distinguished themselves, they said, you know what, look, if you look at this cytokine signature of the patients we've diagnosed as ME, CFS, it differed from rheumatoid arthritis. There was some really like distinctions, so that was impressive. So funny. You keep on mentioning pandas. It's funny. In 2 weeks, I think I'm interviewing somebody from your institution, Dr. Podkor. Do you know him? He's like a pandas expert. I think he's at Arkansas. No, maybe I'm not saying it right.
So who?
Um, I'm interviewing. Uh, I don't have his full name here. It's a long, tough name, but he's
Uh,
an expert on pandas.
yes, I know who you're talking about.
Yeah.
He's called
So
Dr. Panda.
we call Dr.
It's,
Panda.
uh,
What a great name to have.
yeah,
Okay. I'm not going to go into Lyme because we're running a little bit low on time. But basically, I think you've said this is all the same thing. Dr. Harville, what I want to bring up actually at this point too, and this is a little bit more the general stuff for our listeners. I think they're going to enjoy. I often love quoting Dr. Louis Pasteur, the original immunologist and chemist, as yourself. He said, supposedly on his deathbed, it's not the seed, but it's the soil. And I try to explain to patients, the way I interpret that is that the seed is the infection and the soil is the patient's immunity. And that really truly determines who gets better, who gets sick. I know that also you're like an expert in HLA stuff and, which obviously involves genetics and stuff too. Have you come across in your career, again, in your long career, esteemed career, where you sometimes come across patients that were like, wow, I'm looking at their bloods and everything, and clinically their immune system is amazing. And is there anything that kind of stands out to you that these patients had that, that differentiated them? Just curious if that ever existed, possibly.
that's a great question. And I'm looking at the opposite end, unfortunately.
You're looking at the opposite.
I'm looking at I'm looking at the immune
You're looking at
deficient.
where they're in trouble. You like,
Yeah,
right.
autoimmunity. And so
Okay.
I'm looking at where there's fault rather than where there's.
I was just curious if you ever came, because sometimes it happens in a physician's lifetime. It's like you meet that patient, like where, God forbid, everybody died in the community, that this guy lived, or it's like how they discovered in Pakistan, I think it was, like where there was this group of family, whatever, that didn't feel pain, when they
Right.
discovered the gene, what it was. That could be fascinating. Okay. One
I,
other,
I,
yeah,
I was just going to say, I think there may be people like that out there.
I'm sure there are.
What many people don't realize is that significant part of the way our immunity works is because of our usurping the immune components from Neanderthal, and so
Mm,
we are a mixture of hominids that go back to the earliest forms, where where when we interbred, we were able to usurp the immune components that led to benefit in certain areas of the world. And so, for example, if you look at the HLA components that are from northern China, Mongolia area, you find those passed all over into Eastern Europe, down into the Middle East, over into Western China, and follow Genghis Khan's route.
mm.
And what it brought to those people was protection. It helped their immune systems to fight malaria better.
Right, right, right. Because again, as you well know too, in medicine, again, we always use things for the bad things. Like if somebody has the HLA B27 or something, we associate with ankylosing spondylitis or autoimmune disease. I was just curious if in all your work, you're like, oh my God, this person has HLA, DR, blah, blah, blah. And like these people, nobody, they never get sick, or a certain blood type that they're like, wow, if you have type O, again, people have written about this and a lot of it was nonsense. If you have type O versus type AB or whatever, you're, more immune protective. Nothing like that has really ever been shown.
I'm sure there are individuals that have been hit the lottery and had all the right ones present there,
Right.
where the balance is being maintained. I think one of the things that we often mistake, and I think you've been bringing it out, but it's easy for people to mistake, is they get the flu and they think the virus is making them feel lousy and sick. No, it's the immune system's making them feel lousy
Right.
and sick.
Well, that's
And
why
so,
I'm sorry to interrupt. That's why people died with acute COVID. That, initially in the thing, we realized, I forgot what they were doing or how they were treating them, but it was the inflammation that was killing the patients.
correct.
Right. So
Correct.
I think, yeah.
So the point there is that someone that has a strong immune system is
Yeah.
going to have a higher fever, is going to
Right.
have
It's
all
actually
these other
good.
things.
Yeah. It's
Yeah,
actually potentially beneficial if it doesn't get out of hand.
right. As long as it can be controlled by other
Right.
modifiers.
Right.
And so as long as your um, glutathione, your SOD, your superoxide dismutase, all these other factors are very strong, then you limit the extent of the damage that's occurring so that you maintain it into a smaller area.
See, that's my beautiful segue into one of my last topics that we're almost done with. You know, Another super chemist, Nobel Prize winning Linus Pauling, was a big advocate of vitamin C and other
Yeah,
nutrients, and he was, vilified for that. And here this esteemed Nobel Prize winning, I think uh,
twice.
twice, right? Well, one for peace, but also I think, or maybe two in science. I don't know. The guy was just genius. He, I
Both were
mean,
in
he
science. Yeah,
two. He did got two in science.
in
Yeah,
science.
yeah. So, but he was obviously a big advocate of high dose vitamin C and all these things that he did himself and was vilified. Again, with your extensive knowledge and open mindedness, do you think that, supplements done correctly can enhance immunity?
Yes.
Okay.
And so the vitamin C, he took 12 grams a day.
Right.
Okay. Nobody has done a study where you've taken 12 grams a day.
Nobody's
So
done a study on that. Okay.
no, studies have usually 1 gram to 3 grams and so forth,
Yeah.
and not 12 grams a day.
Yeah.
So we don't know for sure that there could be some benefit because the studies haven't been done
Right.
replicate. The problem with 12 grams a day is upset stomach and propensity to develop kidney stones.
Well, I have to be honest. In my practice, I do immunology, but I also do functional medicine. We give people
Yeah,
25 grams IV.
yeah,
And we like to see how they do. I mean, if we can help stimulate their mitochondria and other things, as long as there's really no downside risk, for the most part, there isn't. Why not?
exactly.
Yeah.
So
But I was
so
just,
people ask me, and for people with hypermobility,
Mm,
and we recommend taking at least 1 gram or 2 grams a day. Make sure
interesting.
they're maintained very hydrated.
Was
We
that to
also
help their collagen? Is that why?
yes, right,
Yeah.
yes,
Mhm.
and lysine for collagen cross-linking. So we ask them to take 2 grams of collagen a day. Sorry, 2 grams of lysine a day,
Mhm.
2 grams of vitamin C a day. Maintain themselves very hydrated, prevent problems associated with renal stones. And
Oh,
that's
sorry. Say it again. Oh, by adding the lysine, that helps. You said.
yeah, lysine helps cross-link the collagen. Lysine's needed for cross-linking of collagen. And
Aha.
so by adding the lysine, you're increasing the amount of availability for when they're producing their collagen to produce the cross links for strengthening the collagen.
That's fascinating. Oh, that's great. That's
And
great advice.
now, as far as immune system function, if I want to grow cells in culture and want to do an immune study, I have to put glutamine in.
Huh. Interesting.
And glutamine is utilized directly by the brain and the heart for its immediate function. Glutamine is converted into alpha-ketoglutarate glutarate to directly go into mitochondria for function. So we recommend, and glutamine has been shown, for example, in patients with inflammatory bowel disease, 4 grams of glutamine a day reduces their inflammatory bowel disease symptoms by directly feeding the enterocytes of the gastrointestinal tract, as well as helping the localized immunity to
You said
function.
4 grams? I'm sorry, is that what you said?
4 grams of glutamine a day, yes.
Wow, interesting. You know, and
Uh,
also just going back to vitamin C for a second too. I
yeah,
remember when I used to do some like immune studies in the lab, in my fellowship, that it also had like anti-staph, activity. Is that correct too? Like, against bacteria. I mean, stimulates the immune cells, the killer cells, whatever, to go in there and,
I think it.
augment.
Yeah, I think it does. And again, you can show some T cell activation and, like you said, NK
Yeah.
cell activation.
Hmm.
And the dilemma has been replicating that in the organism
Yeah. Yeah.
and translating what's happening in the cell culture outward.
Hmm.
Um,
Hmm.
but the other thing that is iron, and I found that people that are not killing well and having lots of skin infections may be iron deficient. And
Great
getting
point. Great
the
point.
iron up helps their neutrophils to be able to kill more. And zinc is necessary as for activating the metalloproteinases for killing. And so
Hmm.
25 milligrams of zinc a day can also help fortify the killing function that your cells need.
I'm so glad you're saying all this, because now I think it's validating what Professor Linus Pauling was doing. It's validating what I'm doing in my practice all the time. You know, it's interesting you say that about iron. I had it on my podcast several years ago, but it was really life changing, I think, for my patients. When I would see, especially even young women who had very low iron and were prone to infections, and they would take oral iron, which didn't really get absorbed, didn't really work. I actually would have them go for a couple of IV iron infusions, and it changed their whole health condition, which
Exactly.
was, so it's, again, this podcast is, it's eventually it's going to make me the smartest doctor in the room. But in the meantime, I just keep on, keep on learning.
Yeah.
Anyway, last question, and we're going to wrap this up. But this was extraordinary for me. I hope all the listeners appreciate it. Dr. Harville, what frontier in immunology excites you the most that you're hoping to see in your lifetime, or that's going to, maybe change, medical care?
What I'm hoping to see is further um, changes in the way we activate, modify T and B lymphocytes so that we can. So, for example, instead of me having to give you a vaccine to make these cells function, is take the cells out, modify them, and then replenish these in the people. And so every person at some point would have cells taken out, would have the cells modified to provide them with the natural repertoire of what's needed to provide them with protection from the microorganisms, from cancers, and from
Mm.
autoimmunity.
Yeah, it's interesting. Steven Rosenberg, many years ago, I think it fell a little bit by the wayside. He was trying to do something like that a little bit with T cells and interleukin, and
Yeah,
bathing the cells with that, and then infuse them back in the patients, and
correct.
he was getting some remissions. I mean, some like in metastatic melanoma, which was unheard of.
That's
There was a
correct.
lot of toxicity with it. I don't really know where it went with it, but he was trying to, like you said, try to break away from. Because we all know sort of instinctually, like, chemotherapy can't really be good for us. I mean, we're killing the bad guys, but we're also killing a lot of the good guys. It's a heavy toll. It's a heavy price. It's like instead of having a surgical, hit, it's like a cluster bomb,
That's
you know.
right.
And in immunology, we like perfection. We like eloquent, right?
Yeah. But like you were mentioning years ago for HIV, with patients who are having lymphoproliferative disease due to EBV, we take out the cells, stimulate them with interleukin 2 against EBV, and infuse them back in
I
to
didn't know
treat
that. Wow.
EBV, LPD that were occurring. And we're doing the same type of a thing with patients with Liskott-Aldrich syndrome
Mm,
that had EBV driven lymphoproliferative disease. And
mm.
so yes, that's a good way of doing it. But if we can alter the cells to be ready for it, then we're not chasing the horse out of the barn.
Hmm. Well, this was quite a discussion. I hope my listeners were as enthralled as I have been. It's my first time meeting Dr. Harville, but he is as good in person or on Zoom as he is in his articles. Dr. Harville, is there anywhere people want to follow any of your work that they can keep up with what you're on the cutting edge doing?
If they just search on my name and COVID, search on my name, MCAS, like you were mentioning earlier, mast cell activation syndrome, search on my name and CVID, SCID, you'll find lots of things in some presentation.